Health Information in the Law Perspectives from the Field interview series. Today we are speaking with Kavita Patel, Managing Director for Clinical Transformation and Delivery at the Engelberg Center for Healthcare Reform at Brookings Institution. She is also a practicing primary care internist at Johns Hopkins Medicine. Welcome, Kavita. Thank you so much for joining us today. Would you please tell us a little bit about your current position and your work and how it intersects with health information exchange?
Sure. Thank you for having me. I am currently in two capacities working on health information exchanges, one at a policy level through my role at the Brookings Institution, where I take the lead on a lot of technical advising for new payment models and how we think about changing our delivery system. And the topic of information, just generically, is literally on everyone's conversation list when we do talk about delivery system reforms. And then as I work at the practical level as a clinician, and I'm in an accountable care organization, we're a patient-certified medical home and do a lot of population health type of work, we also talk about information. And so the concepts of what a health information exchange and just the basic importance of data in a timely fashion, as well as how we think about transmitting information to other stakeholders is something I play on both sides of, from a policy level and a practical level.
That's wonderful. So you have a bird's eye view, really, of the policy issues and then also the policy issues in practice as you apply them in your practice.
Right, exactly.
Speaking of payment reforms, what do you see as some of the most promising efforts to reform the healthcare delivery system, particularly through the greater use and exchange of health information?
So the biggest promise around exchange of health information is in literally the action of having parties who are invested in a patient or a family or a population's health have access in a timely fashion, but also the kind of modality in which that information is exchanged is just as important. So we have technical infrastructure right now for you and I to, if we can get past some of the privacy regulatory concerns that I think are important, but if we can kind of go even a step beyond that, we have access to lots and lots of data. And so when we talk about exchanging data, people feel sometimes like, well, if we set up a cloud server and have a password and username, and you can kind of go into a system and look up your patient, that's data exchange. That's actually not what I found is kind of the most valuable aspect. It's really how can someone like me at a clinical level, when I'm dealing with patients' issues, think about the data exchange that would be the most relevant to other parties. And that can be the basics, lab information, demographics, clinical data around medications. But oftentimes it's actually trying to capture what I need to convey in a very succinct format, and what is it that the receiving party really needs to look at in a quick and efficient manner. I've been on the receiving end of what I would say are literally dumps of data that then I honestly don't have the time, desire, or incentive to look through. So I think meaningful data exchange is still something that our country is struggling with. When you're working in a closed system where everybody's got the same medical record and has access, think of like Kaiser or some of these more systems that have been around for a lot longer, more kind of evolved systems, it's easier, but that's actually not reflective of most of the real world. So I can give a story from a patient today who called me from an ER that's not affiliated with my clinic. And he was telling me how the ER doctor was asking him a lot of questions, and he's like, well, let me call my doctor because I don't know these answers. I don't have a way to push information, getting back to your kind of what's the value and benefit of a health data exchange or health information exchange. I actually don't have a way to transmit that right now except to do the good old-fashioned phone call or fax, and that's it. So I think that our country is really just still trying to get into what meaningful health information exchange is.
So it sounds like from your perspective, moving forward and trying to achieve more meaningful data exchange is one of the key goals. And you mentioned privacy issues as well as just, I think, what you're referencing is basic infrastructure issues in terms of how do you send or supply meaningful data in a timely way. Are there other barriers that you also see to achieving these goals?
Yeah, I think something that comes up a lot when I'm doing payment reform work at a policy level that I don't know if clinicians think about is the integration and incorporation of administrative and clinical data. So a lot of what I just talked about is, and a lot of what you see health information exchanges that are being built around the country, Indiana, Cincinnati, New York, Colorado. I mean, I'm familiar with a lot of the kind of regional efforts. When you see these efforts, a lot of this comes from kind of tranches of data. Some are administrative, some are clinical. Rarely do you see a meaningful integration of the two. So when we think about information that's really important for new delivery system models, for doing accountable care, like I mentioned in the ACO environment that I'm in, I need to not only understand kind of what's happening with my patients clinically, but I need to also know how has this patient's total cost of care been over the past year? What are there some flags around prescription drugs, and could I have been doing a better job because I see now that they're paying out of pocket for something that they didn't tell me about that was on Tier 3 of a formulary? Some of those things really are not sufficiently described within the clinical data infrastructure, and you need access to administrative data. So I think that the conversations around health information and health data exchanges in general would benefit from perspectives of people at various points in a delivery system, not just the clinical front line, but also kind of the medical directors, the practice administrators, people who are also thinking about the larger policy framework of what the data exchange means.
That's very interesting. So connecting, from your perspective, the policy issues with the practical issues, so thinking about those issues in a more coordinated way. As a practicing physician, you've, I'm sure, seen the use of health information, exchange of information evolve over the years. What do you think are some of the most promising changes that you've seen?
Promising changes in just practice?
In terms of being able to exchange and use health information.
I think the most... Yeah, so I would say the most clear example to me has been kind of automated alerts around emergency room and hospital discharges. So it sounds tragically simple, but in the majority of the country right now, we have no idea when patients are actually going to an emergency room or admitted to a hospital, or even worse, discharged from a hospital. And I think that the incorporation of kind of what we call automated discharge alerts or automated admission alerts into some of the data exchange has been huge, because what it gets at, there's a phrase, kind of meeting patients where they are. That's how we think about person-centered care or patient-centered care. We don't have the information to actually do that. I have no idea, where patients are getting their care unless they're in front of my face. And so I think that one of the most meaningful developments has been the integration of kind of real-time utilization data, like I said, by ER use, admission or discharge. And I think that's been a tremendously valuable asset. Another aspect of data information exchanges that I think has been in the District of Columbia that I know that we're trying is around medications. So there's been a lot of conversation around the use of controlled substances, and I know there's a lot of national attention on that. So in our District of Columbia Health Information Exchange, we now have a broad network to know when and how patients are receiving controlled substance prescriptions to try to, one, understand and curb any abuse that could be happening, but then two, to highlight that there might be a patient with a real problem if we know that they're seeking drugs and there's behaviors that are going to other facilities. And it sounds amazing that in 2014 we didn't have that before, but we didn't. And so I think those are two kind of tangible developments that shine in the use of information exchanges.
That's great. And I think we're definitely seeing more and more physicians and other providers move towards use of electronic mechanisms of sharing information, either with a registry or participating in automated alerts or other types of information exchanges. What do you think remain as some of the challenges that physicians still face, though, in moving towards greater use of electronic health records and other forms of health information technology to support sharing health information?
I do think so. There's the infrastructure barrier, right? I mean, I know we've had conversations, and there's certainly money had been devoted to getting doctors to get electronic health records, but we're still at kind of the bare bones with meaningful use stage 1. I mean, if you look at kind of what goes into like meeting the criteria for some of these like basic meaningful use requirements, one, most doctors would tell you they're not as clinically relevant, and they're nowhere near kind of where you and I would think about as patients what we want our doctors to have information around. So just even something as basic as interoperability is not part of, meaningful use stage 1 or even stage 2. This is conversations that are so political about when to do these things, but I think that's a big one, the infrastructure needed. And even if you pay doctors, they'll get an EMR that isn't necessarily compatible with other ones because we don't have interoperability. So you can have an electronic health record if you decide to invest in it, but then it won't speak to anyone else's records, and that's a big barrier. That's a huge problem. I would say then so that's two barriers: getting the infrastructure in place, and then kind of its interoperability and ability to speak with each other. I think the third one is also pretty basic, and that's this kind of, I think it's this behavioral characteristic about sharing information in general. So I've even called and spoken to other doctors' offices trying to get information for one of my patients, and the doctors will say, well, for HIPAA reasons, I can't do that. You need to have the patient call us, and then they have to fax us this form. And if you actually look at the barriers to how information can be exchanged that's clinically relevant in real time for an actual patient, honestly, it will frustrate you, even if those two doctors and their offices have those electronic health records in place. So I'm not saying that HIPAA is not a concern, but I do think that it tends to still be cultural for practitioners not to share information. And I think that there's something that we need to do. There's a big movement amongst patients about, owning their data. And the Blue Button Initiative at the federal level and Medicare, where you can download your own data and it's yours. I think that's just really at its kind of, infancy. And I think we need more movement to have patients have and own kind of their medical record, but it also has to be in a format that's not just, 500-page data dumps that make no sense. And that gets back to the information in data exchanges being meaningful. Doctors like me don't just want, your past 20 years of medical records. We need certain pieces of information, and it's how do you get that out of a system into the hands of someone who needs it.
So it sounds like some of the things you may be referencing in terms of discharge documentation or care summary records, things of that nature that would actually encompass or collapse a broad range of information into a very usable document that can either be shared by the patient or shared electronically, but would help foster sort of more of a culture of sharing, basically.
Right. I've often thought of it, and I've told my own patients, like an executive summary of your medical problems. So I've told my own patients, like, in your medical record, I've got what I would say is an active problem list. I don't care about something that happened 30 years ago, but here are my active problems, and here are the surgeries I've had, and here's kind of my active medications. I've actually said, like, if you do nothing else, you need that information along with your most recent set of labs. And I said, and that will help me more than anything in probably the binders of data you bring me. So I think getting people to also understand exactly what you said, but getting them to understand it at a practical level is where we still have a disconnect.
Definitely. So in thinking about, I think, the three challenges you identified: infrastructure, interoperability, and then changing the culture around sharing. What strategies are you seeing or do you think hold the greatest promise for encouraging greater exchange of health information across providers and with patients?
So I do think the number one thing is to advance the meaningful use interoperability recommendations. There's been a lot of politics around it. You can imagine that there's influences and interests in potentially keeping proprietary products proprietary and not sharing. But I think that could be the most important thing. If my EMR can talk to that doctor's EMR, I don't need to get on the phone and beg them to fax me something. So I think that's a huge policy issue and it's out there. It's not as if the policy community hasn't weighed in on what these interoperability standards should be. They're just not being implemented. And so I think implementing those and enforcing those would be a huge policy directive. I think a second thing is a little bit more of that pragmatic piece of education of clinicians, that exchanging information is not going to get you into legal trouble. I just have to be honest, a lot of what doctors, when they don't want to send information, has nothing to do with not wanting to help. They don't want to get into trouble and get flagged with a HIPAA violation. And I know that because even there are times when I feel that way. So I think that those two things, the meaningful use, interoperability standard implementation and enforcement, pairing that with the education that a lot of us get from our colleagues in professional societies would be two huge ways to overcome these obstacles.
Wonderful. Well, Kavita, we really appreciate your time this morning. This has been incredibly helpful.
Oh, great. Thank you so much for having me.